For sure.
I should have brought my my water bottle downstairs. I've served with the NATO forces in Africa, and the Swedes gave me a really cool water bottle from their army. So, you know, we all trade, you know.
So you have a Swedish water bottle.
Yeah. And I have a couple of other like patches and different things from the Swedes and from the Japanese and from the Germans. You know, we all just trade our uniform items, you know.
That's cool. I had no
brought
idea.
It down and just like conspicuously stuck it right here, you know.
That would have been something.
Yeah.
Yeah.
Give me some credibility with your people, you know.
Of course, bonding. Okay. Welcome everyone. I'm here and I'm so happy to be here with Dr. Mary Vieten. And she's a board certified clinical psychologist. And you've been working in the military for 22 years, but retired now in May. So again, very happy to have you with me. And I would like to start our conversation with a passage in the movie that really struck a chord in me, or it really affected me actually. And it's this short passage where you're talking about the DSM manual and how it's really not researched in the way we might think. It's more about stating behaviors, and stating behaviors not on the basis of a test or physical test or blood test or MRI scanning or anything like that. It's a group of people who decided that these behaviors are sick or abnormal. So I would love you to talk a little bit, how did you, because it's such a strong and clear position to me. It's something that I, as a psychologist, also noticed, but it took me a while. Yeah. It's not what we were taught at the university. So how did you come to that position?
So I had the same experience in my university, that the Diagnostic Statistics Manual was taught as absolutely inerrant, and it was taught as pathology, and it was we were told that there were clear clinical underpinnings for everything, or if there weren't, they were about to find them at any moment. So just relax, because we'll find them. And I, when you're in graduate school, you're busy and it's very stressful. And so it's just easier if you just swallow the whole thing whole and move on. And so I didn't question any of that. And then when I moved out into my career, what happened was I ended up in a position where I was just seeing the system kind of fail. And at first, it was the drug thing that hit me. And I realized that people who were getting put on psych meds would actually deteriorate instead of improve. And it was just, that was the first step, was going in and reading the literature and realizing that that was not my imagination, that those were actually the clinically expected outcomes that people were not told about when they accepted the medications. And then a couple of years after that, I went to a conference of an organization called the International Society for Ethical Psychology and Psychiatry. And Alan Francis spoke there. And I was introduced to, his criticisms of the DSM-5 and read his book. And it was such an awakening. And then it just wasn't a big leap to realize if there's something wrong with the 5, there's something wrong with the 4, the 3, the 2, like where did we start? And I started to just really consume that literature, and I understood for the first time that everything in psychiatry is not diagnoses with pathology underlying them, but rather they're constructs, just like in psychology, they're just constructs, and they are all the sum of their definition. And so the clinical criteria that you read in the Diagnostic and Statistics Manual is actually just the definition of the construct at the top. And so you're in this kind of closed loop. So that was the first problem, is that these are not clinical illnesses at all. And so then I ended up in an even worse place in my mind, because wait a minute, if these drugs don't treat anything and these diseases aren't things to be treated, like what are we doing? Like you're taking a theory for your construct. So it was almost like cognitive dissonance, la la land or something. But the more I looked into it, the more it became also absolutely apparent that psychiatry made no attempt to hide this from the public whatsoever. All of what I was looking at, what I was reading was easily accessible. It was in the public domain. Some of it was on their own website, the American Psychiatric Association website. And then I started to get interested in the money influences and the political influences, and the whole thing just kept getting bigger and bigger. But it still, at the end of the day, boiled down to the fact that people, including myself, were sitting in offices and convincing human beings that they had a disease when they had nothing. They simply came to you with some level of human variation or some level of human suffering that psychiatry had co-opted and said, we're in charge of that. And we will provide the treatment for that and tell everyone else how to provide the treatment for that. And it was, it just the lack of ethics and the lack of humanity in this, just really began my mission.
Mm. So, yeah, and I can recognize that cognitive dissonance, or it's almost like shaking the whole reality in a sense.
Absolutely.
So then the question often is like, what did you start to think or do instead when someone was coming to you, for example, with a problem or grief or pain or?
Yeah, it's an evolution, because that you have a system that requires you to diagnose. The military certainly does, in order for the person to come back and see you. But then you're in this sticky place, because if you do diagnose them, then the military may not want them anymore. So how do you help them without, putting them in that position? How do you normalize that for not just for the institution, but for the human that's in front of you? But if you're in private practice like I am now, it's really the same thing. The insurance company is not going to reimburse you for a normal response to stress. They want pathology, and so you got to provide some. So it was a long evolution to where I am now, and I'll jump to where I am now. But what I do now is basically I give everybody in my private practice the same diagnosis, which is that the ICD-10's unspecified adjustment reaction, because I just figure we're all adjusting all the time, and it's the most honest I can possibly be. And I could certainly argue that, case very eloquently, no matter what. So I feel comfortable with that. But the other thing that I do methodically is part of the informed consent is I'll take 2 or 3 sessions, and I will explain to the person in front of me exactly what is going on and what the perils are. So they understand the diagnostic perils, they understand the medication perils, they understand in our culture, there are lots of cultural implications for having a label. Things like you may not be able to buy a gun, or you may not be able to join the fire department, or, as a volunteer, or there's all these different things you're shut out of if you accept these labels. And, so I make sure that they understand the implications of just saying, oh, it's fine, just go ahead and diagnose me with something, So, that's what I do, is I just make sure that fully informed consent is probably the most serious thing that I do. And it's also one of the most healing things that happens in my practice, because when you fully inform someone and suddenly they realize that this thing they thought was major disorder, they thought they had, major depression or bipolar disorder, or they were, adult ADHD, all of these crazy labels. And when they realize that there's nothing, just absolutely nothing there, except their individual humanity, then all of a sudden, the healing just begins right there. So I don't know, does that answer your question?
Yes, absolutely. I'm just nodding and listening, because it's so interesting what you're describing, because I've also heard, and I don't know if that's a narrative that goes with the diagnostic system and with the drugs for that matter. People saying, oh, I was so relieved when I got my diagnosis. Right. Because I got an explanation of why I am, why I'm like the way I am, and so on. Right.
It's absolutely mesmerizing, because what happens is when they get those diagnoses, it lifts the responsibility off of them and puts it onto the provider. And in that moment, I'm sure there is this rush of, oh, thank God it's not me. But they also completely lose their agency and hand that over to the provider. And it's usually a very short period of time before they start wishing they had their agency back, because things are starting to be denied to them. They start to feel terrible on the medications. Sometimes they're so medicated, they can't even make their own decisions anymore. And it's all because they accepted that diagnosis as the answer. Mm. So, and again, part of what I do a lot of times with my clients is I'll, just spend time walking that back. And it can sometimes take weeks. But walking back for someone, why were you labeled bipolar in the first place? And a lot of times it has nothing to do with their behavior. A lot of times it just has to do with the fact that the person who interviewed them only had 8 minutes, and they described something very, I don't know, womanly. So you must be bipolar and histrionic, and bam, that's in the chart, and now you're medicated. So, a lot of times just getting people to own those parts of themselves and their, their ability to control themselves is huge.
Mm, yeah, and that's such a good word, agency, in this case, because it's, taking on the diagnosis and also, of course, the drugs, as you say, which is kind of not allowing us to process, for example, grief or trauma. So the agency is, for me, is kind of almost connected to the healing.
Yes, absolutely. I'll actually have patients, or I don't even call them patients anymore, to tell you the truth. I just stuck with the word people, but people who come and see me who will get off all the medicine, about 6 months later, they're finally getting over all of the withdrawal symptoms. And I'll say, well, what's it like? And they'll just grin from ear to ear and they'll say, I'm back. And it's just so cool. It's inevitable. Some version of that comes out of everybody. And they're so delighted with the fact that they are in touch with their own humanity again.
Mm. God, that must be such a rewarding work. Mm-hmm. Yeah. So do you want to talk a little bit about Warfighter Advance? That is on your sweater there, the label.
It's my favorite subject in the whole world.
Yes.
So Warfighter Advance was actually born out of what I saw in the military, where people would come back from combat experiences legitimately traumatized. And also they would come back from just all kinds of high op tempo work, very stressful work. And it changed them, even if they weren't particularly traumatized. Just being in that life and death environment all the time changed them. And and all of the things that they came back and felt and experienced, they were told by the military, if you have any issues at all, go to the doctor. And then, of course, the doctors labels them with something from the diagnostic manual, and then the merry-go-round starts. So, and again, I was watching these men and women deteriorate, sometimes commit suicide, reading the literature and realizing that was a predictable outcome. And I just said, we have to do something else. There's only so many funerals you can go to before, it kind of hits you like, not only is this not the right paradigm, but I just can't stand by and watch this anymore. It can't be that way. So, a lot of hard work and many years later, and we ended up with this concept for Warfighter Advance, but it really is a big piece of it is, bringing the warfighters together and remediating that informed consent that they never got, that for their label or for their medicine or for any of the other treatments they got involved in. So remediating all of that, it takes about 6 hours, almost without drawing breath, to give someone enough information that they could say yes or no to a psychiatric medication. I've sort of boiled it down to an art form. And in order to tell them everything they need to know, to say, yep, I'm going to do that, or nope, I'm not going to do that, it takes about 6 hours, and the average doctor's appointment in the United States is 8 minutes. Yeah. So think about that. You just by definition, you cannot get informed consent. And the drug companies would say, well, we put it all in the label, so and some of those labels are literally several meters long. I kid you not. And I don't know how your packages are, but the they pull out the paper and it literally is several years long.
The text is like a millimeter or something.
And then that abdicates the responsibility to tell the warfighter, so we basically, take that and in the barest, most minimum way, remediate that for not just for the medication, but for treatment itself, for allowing yourself to be labeled and to go into those environments. What are the things that could happen? That's all supposed to be told to them, prior to their appointment, which it never is. So we do that, but we also, at the same time, we have in this week program, we impose healthy living on them. Some of them go to that kicking and screaming. So they actually eat, 3 meals a day. They have healthy snacks. We remind them to drink water. We're very cruel and we cut off the caffeine at 10 o'clock in the morning. So after 10 o'clock in the morning, there is absolutely no source of caffeine. And they start to sleep better almost immediately because they're not taking in a stimulant all day long. So at the end of the week, not only have they learned a lot, but they've also began to just feel better. And they can't deny it. At the end of the day, I feel better. I just don't want to admit it, but I actually do, And then we do a lot of things with team building that are very specifically designed to counter the patient model, which is, of course, you need me, you have to come in, you can't stand your stress, I can help you with that. And instead we put them in very stressful situations and show them, not only can you stand this stress, but you can actually operate under this stress, just like you did in the military. And there's people around you who are ready to ensure that you don't fall. And that you meet your goals. And so, and so with that team building, one person dealing with the stress of the rest of the team, making sure, then that sense of camaraderie and family and, oh my God, I can totally do this, it really comes back. It's absolutely amazing. So we even have sometimes Vietnam veterans who are in their 70s who will get up and finish these challenges because of the fact that they may be, getting up there a little, but with the ground support, they can do anything. And they figured that out pretty quick. So.
Wow.
Yeah. So they want to make that video for their grandkids,
Yeah. And that certainly highlights the great importance of the safety and of the social safety or the being held in a situation.
Right.
Because that's one of the things, right? Is feeling isolated.
Absolutely. And the psychiatric model is designed to make people feel isolated. You come into the provider's office, you tell them their troubles and they shake their heads and like, oh, like you're the only one, but I got the answer. And when they're sitting in this group, and spontaneously saying, well, that happened to me too, then all of a sudden the mystery of it goes away. And, I'll bring up examples and they'll say, well, how come you know that? And like all 20 of them are like, how come you know that? Well, because I deployed too. I had to come back too. I had to figure it out myself. So I know what happens and I know what you're going through. And the isolation comes literally from the treatment process, from saying, oh, well, this is private stuff. We're not going to share this with anybody. It's just me and you, And so, we're not running a treatment program. This is purely training and purely education. But what happens is that it becomes very therapeutic when people realize, wow, I thought I was the only person who was going through that. I thought I was a nut.
Yeah, it must be extremely liberating. And at the end of the week, then, is there some kind of decision they make, or is it more, what happens normally?
That's a really interesting question, because it is a training model. So, and also I have a theater background. So, I'm like making sure that certain things happen at certain times and everything is, perfectly timed for effect. So one of the things we do is when we bring them in on the first day, we bring them in on a Sunday, and very specifically on Sunday, because a lot of the people in the community will have the day off. And so we invite all kinds of community leaders to come out on Sunday night. And we have this gala dinner, tablecloths and flowers in the middle and, all the things that you expect from a very nice dinner, just a beautiful dinner. And the mayor of the town comes and the commander of the base comes, and we have all these other politicians that show up and some of our donors show up. And basically the idea is, welcome to the journey, and you're starting a journey and we just want to wish you well. Everybody's got a shirt like this. Even the mayor's got one. It says Mayor James on it, So, everybody comes in this. And so there's no, like, you're the patient and I'm the doctor. Everybody looks the same. Everyone's got the same thing on. It's all, like I said, very carefully orchestrated. So that night you can see the people who are new. There's always 20 of them and they're scared to death. They're just, and they're very medicated and you can see the tics and you can see the, all the stuff. But they're frightened. And then you see what happens over the course of the week as they bond and as they go through the activities and the learning and start to let go of, I'm a mentally ill person and I need to hide all my stuff because I'm mentally ill. They just let go of all that. They take their agency back. We don't control them in any way during the week. So we're not like looking in their suitcases for pills or nothing. You're in charge of you, just participate, So we give them all their power back. And so at the end of the week, what was this person who was scared and like, you could just see it physically, they're sitting back. We have a graduation on the last day on Saturday morning. It's a graduation and they're sitting back, in their chairs and they're laughing and they're, calling each other out on their crap. And, just kind of like the old days when they were in the military before they got diagnosed. And then, we give them a graduation certificate that's basically making them a subject matter expert. So in operational stress and, whatever the situation is, but, again, no diagnostic labels, no medical terms, no nothing, just, welcome to your new life. Here's your power back. Go. But what happens is too, that they have bonded so tightly as a group that going forward, when they graduate, they go into our alumni association. And those 20 are kind of a cohort that, if you look on our website, you'll see everybody has Evo something after their name. So that was their 20. So Evo 16, Evo 17, and it means evolution, 16, 17. So everybody identifies with their evolution, but they also identify with the larger alumni association. And so they'll have social events and they'll meet each other and support each other. And, things do get dicey. We're humans. So they'll rescue each other if they have to. But the amount of support that they provide for each other and without any clinician whatsoever being involved, it's just absolutely phenomenal.
Wow. When I'm listening to you, I'm thinking, because this, of course, is a military setting and the team is important in the, in what you do. But I'm also thinking how much that influences the actual getting the power back, the way that they can socially kind of mirror each other, support each other. So I'm wondering, a person who's not in the military.
Yeah. We have generalized it to other groups that are similar, like police and firefighters and that kind of thing, where they have the high up tempo experiences but I really do think it would be possible to do this in the civilian world. You just would have to work on that paradigm a little bit so that you're bringing a group together and creating a sense of family and a sense of support that, I think humans are actually kind of longing to have, but also to give to each other. So I'm probably giving myself away. I'm an Adlerian psychologist, by the way. So, creating context and not ignoring context is everything. And so, that's what you really have to give the thought to, is what are the contexts these people are coming from, and what are the contexts they're going to return to, and how do we create a very supportive layer of context while they're here. So
yeah, it must be, well, I'm with you in the sense that me too, I'm like into social constructionism and all of that, and I realized the importance of that. So maybe I'm also biased in a way, but what I'm thinking is a person, for example, here in Sweden, is on sick leave, medicated, and that isolation, what it does to a person.
Right.
And even coming back to work, you're singled out in a way. Oh, that's the burned out Frida coming back,
Absolutely.
So it's not really going back into a safe social setting.
no.
So hearing you telling this it's very strong.
Yeah.
I don't have any answers, but it's definitely striking.
Yeah, just in the moment when that employee, whoever they are, needs support the most, it's removed. You know, that's the other thing is, you know, go and stay home. I mean, we do this with police officers in the States when they make a mistake. Go home and sit in your house and think about that for 2 months while we investigate it, you know, and don't talk to anybody. You're ordered not to talk to anybody because it's under investigation, and that person just spirals downward because this is the moment when they need to talk to their people the most, and they can't.
Yeah. And it's true. You also mentioned that in the movie when you say that if it would have been 100 years ago, we would have talked to each other, to your ministry, to your family, to your friends.
Yeah.
Do you think we lost that social support, or whatever we want to call it?
No, I think it's there, but I think two things happened. One is that it's been literally co-opted, you know, that so that people will say, well, go to your doctor, instead of saying, you know, do you have a chaplain? Go talk to your chaplain, or go talk to your friends or your chief, or, you know, something like that. Maybe your mother. You know, I've actually had that with sailors where I've said, have you told your parents this? And they look startled, like, why would I do that? You know, they're your parents, dummy, you know, and then they do, and they come back the next week and they're like, wow, that was cathartic. Like, they understood me. In fact, they told me they had a problem like that when they were my age, you know, but they don't think about it. They came to me. That's what I'm saying, is they were told to go to the doctor. They came to me, and I'm thinking, why didn't you go talk to your parents, you know? Mm. So, and I'm become this, you know, clinical genius because I cured them, because I told them to go talk to their parents. It's crazy. but I think the other piece of it is, you know, because there is this drumbeat: go talk to your doctor, go talk to your doctor, go talk to your doctor, get that yellow piece of paper, you know, stay home from work. You know, but the other piece of it is that even people who would normally like to help had this drumbeat pushed into them that if people say certain words, you need to tell them to go talk to somebody. And that's the code for go to the psychiatrist, or go, you know, talk to the doctor. And so someone who's perfectly capable of handling the situation, like a peer or a parent or a chaplain, immediately gives away their agency in that role and says, oh, we need to go to the doctor and make an appointment. You saw that in the movie when the girl said, or told her mother, I've lost 20 pounds. Yeah. And instead of the mother saying, well, we need to look at what you're eating, maybe bulk up a little bit, maybe, you know, something, you know, but instead she says she made an appointment immediately. It didn't even occur to her to handle that as a mother. That's true. And that was such a defining moment for them. Absolutely. Absolutely. But so everyone's human agency and agency as a peer, as a mentor is gone, you know, because, and part of that is, you know, just the drumbeat and hearing it all the time, but also part of it is people not wanting to be liable if they make a mistake. So in our country, we sue everybody. So, you know, if I don't send you to the doctor and then you do something crazy, you know, then I'm afraid that, you know, your family's going to come back and haunt me. So I just punt that responsibility as fast as I can, you know, into the medical world, but much to the detriment of the, you know, the individual who's having a problem. Yeah. And also as you say, taking away, it's very much a power relation. Mm-hmm. So where we position ourselves and the agency that we see ourselves as having in such a situation. Right. Yeah. Okay, so just one more thing that I want to cover. We have touched upon that a little bit, but I'm thinking about the medication part and how it kind of take away the possibility for us to process, to grieve. Mm-hmm. And your view on that also when it comes to trauma. What happens if we have a traumatic experience and then we very quickly start medicating ourselves, and knowing that everything that does to our cognitive and emotional capacity or resources? Yeah, I mean, I think the most obvious thing that this does is it delays the work that inevitably needs to be done. And so, you know, I will see people come off of the medication and then realize, oh, I'm right back where I started. In fact, there was a young lady in the film who said that, you know, the same young lady where she said, well, I got off all the meds and there was the problem that was there in the first place. Yeah, true. And so this is very, very, very common. You know, you'll see the young men, they'll have an experience. Sometimes it's related to war. Sometimes it's just related to maybe a mishap. Some very gruesome mishaps happen in the military. And they'll witness those things, and they'll carry that around. And what they realize when they taper down off all the meds is that they're still carrying that around in the exact same way. They've made no progress. So, and most of them just want to start doing the work. Some of them are bitter. You know, I thought, you know, what's fascinating, and maybe if this is not interesting to you, go ahead and cut it out of your film, but what's absolutely fascinating is how many people come to me in my office, but also come to Warfighter, who have fully believed that post-traumatic stress disorder, or even major depression, which is what we now label grief, they believe that they are clinical problems. And if they just find the right combination of pills, that it's just like having maybe a strep throat or some kind of bacterial infection, that one day they're going to wake up and they'll be cured because they had a disease and this is the treatment. And they're just absolutely, I don't even want to say that they're simple-minded, because they're not. This is the way it's presented to them. Just, you know, stick with us, we'll find this right thing, and then you'll be fine. And when that onion is peeled back and they realize, wait a minute, you mean if I keep taking these forever, I'm just going to be like this or worse? You know, and my abilities are going to continue to deteriorate, and they're going to continue to harm my brain and harm my everything right down to my bone marrow, you know. And it's like, yeah, that's pretty much what's going to happen. And they're shocked. They're absolutely shocked, because they were convinced that they had a disease, and it was just a matter of finding the right chemical response, and everything would go back to normal. They would be like they were when they finished school, you know. And everything would just go, you know, snap back into place. And they're committed to the treatment because they're committed to this end, which they thought was coming. And they really believe it hasn't come because of something wrong with them, you know, that they are somehow defective or failures, you know, or outliers, like a special case, like everybody else gets better. Otherwise, why would they do this? You know, but I'm not getting better. There must be something specifically even bigger wrong with me, kind of thing. So it's absolutely it's absolutely tragic to watch, you know, to see that, but it's also amazing to see the liberation when it just finally the scales fall from their eyes, and they're just so like, if I keep doing this, like, I'm not going to actually get better. That's right, you're not. And you know, and the thing is, I'm not telling them that. I'm just laying out the science. And then they realize it on their own. They go, wait a minute, if that's the science, then this cannot help me. And yeah, that's, you know, I don't have to tell them it's never going to help you. They realize it on their own.
Yeah. And also living with it probably for years and years. So
yeah.
Wow. Just to finish off, what has been the reactions you have met when it comes to medicating normal?
Almost all supportive. You know, so I have been on a couple of panels, and before COVID, I was on a couple of live panels. And I think most of the people in the audience who were thinking like, oh my God, you know, they really didn't say a whole bunch. There was a lot of just overwhelming support. I have done talks before where there have been psychiatrists and psychologists in the audience who were very, very angry that I would, you know, present this material, but they never stood up in the talk and asked a question because they knew I wasn't wrong. What they would do is they'd wait until afterwards and they'd come up to me and one-on-one, they would say, why are you telling them that? Some version of, you know, why have you told them that the emperor has no clothes? Like, who is that? Who does that help? You know, and I think that's appalling, but, you know, I just very quickly tell them that, you know, it's just informed consent. I'm just telling them what the science is. And if they want to go on being treated that way, it's completely fine with me, as long as they know what they're doing. So, you know, I won't get into it with them, but I have never had someone, you know, stand up and say, that's not true.
No, because it is, as you say, it's all there.
Right. It's all in the public domain. It's all completely accessible.
And that just shows how extremely strong this narrative or marketing or whatever we want to call it
Yes.
is that even though it's all there, and also people, of course not everybody, but a large amount of people taking those drugs are not feeling better.
Right.
And still it goes on.
Right.
That this is the treatment, this is
Right.
the thing.
Right. Yeah. And they're so desperately addicted sometimes, and they don't realize that. Every time they start to taper down, they do it too fast, and then all these symptoms occur, and they, you know, then the doctor says, well, see, that's your underlying psychiatric condition, you need to go back on the meds. Then when they take them again, they calm down, and so they're like, oh, see, that might be right. And it just reinforces that underlying condition idea. But when you can sit down and say, okay, this is what you should expect, you're going to feel like this, you know, then the warning is there. And when that comes, they attribute it correctly to the withdrawal and not to the underlying medical illness, which doesn't actually exist. So it's a completely different paradigm. It's very rewarding to provide that kind of support to someone before they start. And then to hook them up with a mentor who's already done that process, so that everything they go through can be normalized, you know, and it is very rewarding.
I can only imagine, yeah. And because now in the US, informed consent is not, it's not required, or is it required to?
It is required, but it's a couple of things wrong with it. One is that it can be verbal. That's allowed for me to write in the chart, patient consented, you know, and I could have written that 3 weeks afterwards, you know, and who's gonna, you know what I mean? Who's gonna challenge that? Nobody. But the other thing is that even written informed consent is generally given prior to the appointment. So in other words, if I go to see a doctor in this country, they hand me a piece of paper prior to the appointment that says, I consent to this treatment, I consent to this thing, I consent to the other thing. It's because it's efficient. That way everything is in the chart. And then I go in there and I consented to nothing. I didn't even know what was going to happen to me, you know, but if something goes wrong, the psychiatrist just pulls out that chart and says, you consented.
Yeah.
It's right here. And it's legally airtight because you did.
Wow. And of course, I want help. I want, you know, relief. I'm going to sign that.
Right. They don't even read it. I mean, honestly, like you said, small print, you know, sometimes it's on a computer pad now, and, you know, people just scroll through and, you know, they would just want to get done, you know, but I mean,
that's quite some difference from 6 hours, as you have clocked.
Yeah. Yeah.
For what it really takes to understand what it means.
Yeah.
Yeah. Okay, Mary, thank you so much for joining me, and I could go on talking forever, I think.
My favorite subject. After my children, of course, but yeah.
So yeah, thanks a lot, and keep up the good work. I mean, what you're doing is amazing.
Yeah, absolutely. You too. Don't give up.
I won't.
All right.